It's The Elephant in the Dome with Senator Chris Gildon, the official podcast of the Washington State Senate Republican Caucus. Joining Senator Gildon today is Senator Ron Mazzal, the ranking Republican on the Senate Health and Long-Term Care Committee, to talk about the 340B drug pricing program that has drug makers sell medicine at a discount to some health clinics and hospitals that serve low-income patients. Now, here's Senator Chris Gildon.
Hey, well, thank you, Tracy, and welcome to the show, Senator Mazzal, the happy farmer. How are you doing?
We're doing well. We once again, we're in the interim between sessions and plenty busy. Just finished up with another Zoom program and hurried to this one. And between tours and Zoom programs and other meetings, we are staying busy.
Yeah, I know for a part-time job, it sure does seem full-time.
Yeah. My kids expect me still to work on the farm too. So it's funny how that works.
Well, so we have a really interesting and complicated topic to talk about today, and it deals with drug pricing and a particular program that's called the 340B program. And I know whenever we were debating this in the legislature this year, a lot of legislators had a hard time understanding it. So we're going to see if we can talk about it in a way that people can understand today. But what can you tell us about this program?
So it is very complicated, and it has grown exponentially, especially since the Affordable Care Act and then during COVID. So it's expanded considerably. The idea is that some will refer to it as savings. I refer to it as a margin that the drug companies will sell to the Medicaid program at a reduced rate, but they increase the price to others, and then they take the margin out of that to offset costs that hospitals and FQHCs, federally qualified health centers, and so on, to subsidize them. So it was created in 1992. The impetus is that there was a program started in 1990 that had a bunch of problems, so they had to create more legislation to start this 340B program, and so that was the beginning. And initially, as these drugs were purchased through local drugstores and the like, and through the hospitals, it was reasonably equitable, and there was only a certain number of hospitals that received the reimbursement. But that has grown substantially, which has increased the cost then to everybody. Because contrary to common belief, somebody's going to pay the dollar in the end. If you give savings to one person, somebody is going to have to make up the difference. And that's where this kind of all started. And that's a very simplified view.
I may be getting lost a little bit sometimes here, but I'm going to try to break it down Big Bird Barney style if I can.
Perfect.
So at its core, this is a program that was started to provide lower cost prescription medication to people who need it. And so the facilities, the providers would provide lower cost medication to people who need it. And in return, these facilities would also provide some type of indigent care, or what's the return on it?
So this 340B program at its core, it was a condition of these companies selling drugs into the Medicaid program. So it required them, in order to sell in the Medicaid program, they must provide the steep discounts to Medicaid they refer to them as covered entities. Mm-hmm. So the covered entity is the hospitals, FQHCs, and so they serve low-income patients, as you mentioned, kind of charity care, and they receive payments from the federal government to these uninsured patients. And they provide the primary care and medication services to the lower income people. Also to the HIV clinics, which at the time was a big deal in the 90s. So as these have continued, the problem is it worked in the beginning quite well, but the expansion, the scope has changed dramatically, and it exploded in size, as I mentioned, after the ACA in 2012. When it was put in place in 92, there was about 1,000 entities that received this. Well, now there's 5,100.
That's nationwide, right? Not just in our state.
That's nationwide,
okay.
because this is a federal program,
Mhm.
which is kind of the problem. And when it came down to this legislation, it's a federal program. We have a little part of the program we're responsible for, but it's basically a federal program. And so in 2015, 340B was $12 billion.
Wow.
Now it's $81 billion.
So it went from 12 to $81 billion. And that's quite a lot of growth.
In 12 years. In 12 years. I mean, really, and these numbers are from 2024. So that's in 9 years.
Wow.
In 9 years, it increased. And then in that period of time, when it was started off and it was at this 12 billion, 7 billion went to hospitals, 5 billion went to the FQHCs and the Ryan White clinics, which are the AIDS clinics. By 2024, it was 81 billion, and 70 billion went to hospitals, 11 billion to FQHCs. So as it expanded, more and more of that total went to hospitals. Now, let me just say, hospitals are in tough shape, as are the FQHCs. They really need this money. They really
you've got a couple of,
it keeps them in business.
And you've got a couple of hospitals in your district that are really struggling.
Really struggling. One of the two that are really struggling receives 340B. The other one doesn't. And in fact, had a bill that would have made them a critical access hospital and it would allow them to get the 340B money. But the feds are blocking that currently because of some fine print. But the hospitals have to have this money in order to stay in business.
Yeah, I mean, politics is so tricky sometimes whenever you've got competing entities at the federal, the state, the local, and and the bottom line is people need care from these facilities, and some, like you said, somebody's got to pay for it, right?
And today in the United States, 40% of hospitals qualify for 340B payments. And so, yes, we've got the federal, we've got the state, we've got these public hospital districts, we've got private hospitals, and then the requirements on these hospitals to provide care. University of Washington provides $240 million worth of charity care, and the 340B is like 80 million of that. So it doesn't cover the charity care, but it helps, and they need this 340B money in order to be able to do that. But it increased the costs of pharmaceuticals to private insurance, group insurance, the patients themselves, in order to offset the costs of providing care to these hospitals.
Yeah, so there's the bill, right? Like you said, somebody's got to pay for it.
Somebody's got to pay it.
A subsidy on the one side, somebody else is paying that cost.
Yeah. And being as it's a federal program, like I mentioned already, the state has very little control over it or responsibility for it.
And so there was a bill that was that passed last year, or this year actually, Senate Bill 5981. What did that bill do?
Well, it was heavily debated, and I explained the responsibility, but the intent was to impact or regulate this federal program, and it was about controlling. So, being as this program has grown so much, the pharmaceutical companies, who are the one where the bill, the money rests, was starting to limit the amount that, because it had grown so much, the amount that was happening there. And that was the bill itself was trying to control the who they could say no to, because they were saying that, the drug manufacturers would begin to limit the amount of contract pharmacies that they would allow to dispense these 340B drugs, which is part of the conversation. When it started out, we had all these pharmacies. Well, now there's far less small town pharmacies. They vertically integrated. We got insurance companies that own PBMs. We got pharmaceutical companies that own PBMs. We got hospitals that are dispensing these drugs now. We've got far fewer independent pharmacies out there. And there's some contention that these big pharmaceuticals are able to, by using the 340B, are able to capture more volume and profit than what was initially perceived. It hasn't actually been proven to me, but that's the contention. So we've got hospitals that need it, insurance companies that claim that it's costing them more, pharmaceutical companies who say that in order to sell in the Medicaid program, they've got to be involved 340B, that they're being hamstrung in their process, all of which they all have viable claims. And that is, I put together a listening session. There was 30 some people in the room, and everybody was, and they kept talking about savings. I reminded them it's not a savings, it's a margin when you take revenue out of a system. But it is very complicated. I don't see anybody being the villain in the process, but there's a lot of money being taken out of this revenue stream, part of which is being redistributed to hospitals. It was, what level of responsibility do we have on it? And I felt that this bill, I wasn't against the idea of it. I just felt it was beyond our responsibility and our scope.
Oh, so you think that it was the state getting into things that were kind of federal issues?
Very much so. Very much so. In addition, we know that other states have done this, and it has immediately gone to litigation. And that's what happened as soon as we passed this bill, was immediately it went to litigation. And and it's a funny thing. As it's gone through the state courts, it's been about a 50-50 split. The other states have passed this bill. About 50% of the state courts say, oh yeah, this is okay. About 50% of them said, no, this is bad. And it's not a blue and red state either. Louisiana and Mississippi, they said it was okay. There've been blue states, Illinois, and somebody else said, no, this is not right. The pharmaceutical company should be able to limit who they give the 340B to. So it would be nice if Congress would step in and solve this. I don't have much faith in that happening. Watching Washington, D.C., they don't seem to really get involved in real problems and solve them. So I think it's highly likely it'll end up in the Supreme Court, and which will take years. And I wouldn't want to even begin to guess as to what they would do about it. But right now it's in litigation, and there's a tremendous amount of money being spent to litigate this. This was you and I talk about this often. We scratch our heads. This was a tough decision. I felt for both sides on this. The hospitals, I've been a big supporter of the hospitals, and I'm well aware of their financial positions. They need the 340B money. On the other side of the coin, the truth of the matter is this just increases the cost of pharmaceuticals to the general population. And so I had that. More so, I just didn't feel that we as a state had this authority, and knowing that it was going to end up in court, I I'm very hesitant to pass legislation that I know is going to end up in litigation.
Yeah, I mean, it's a little bit of an aside, but I was looking at an email just recently because, we've been talking about tort liability and the state's liability for tort and how much all of that costs. And I saw an email just yesterday that was talking about not only do we have liability whenever the state is found to be negligent or to have caused harm, but we paying like $200 million plus for the state to defend ourselves in these cases. The attorney's fees alone are in the hundreds of millions of dollars. So I get what you're saying. You want to try to avoid things that are going to go to court.
Yeah. Well, it's a real problem, and I understand how people want to be right and so on. And exactly, I heard also yesterday somebody said, "Well, yeah, if they don't pay me, I'm going to sue them." And I thought, do you understand what the costs of litigation is? It's huge, and if it's nowadays, when you look at that, you got to be recovering an awful lot in order to afford to do that. And in this case, I don't know where it's going to end up, but the truth of the matter is that this program, when it started off, was not bad. What has happened with this expansion is that it's being used to subsidize our failure to reimburse hospitals for the care that they provide.
It's turned into a bit of a profit center for the hospitals. Is that what?
No, it isn't,
Correct?
because most of them don't receive enough money. The problem is that whether it's Medicaid, Medicare, TRICARE, Indian Health, 70% of the people that walk into a hospital are on some sort of contracted care, which is less than the cost of providing that care. So 30% of the population in a hospital have to be charged above and beyond in order for that hospital to break even. So our Medicaid rates in Washington State are abysmal. They don't cover the cost of care. A hospital doesn't have a choice when they walk in the door. They've got to treat that person, but they're not going to be reimbursed for the cost of care. So this 340B money has been used to offset that. And that's the reason it's expanded so much, because hospitals are going broke. And there is not enough money being derived from those reimbursements to cover that cost of care. And 85% of a hospital's costs is labor. So it isn't like we can just cut that tomorrow. No, we've got a number of our hospitals that are going backwards as far as their financials are concerned. And this is part of trying to reimburse that, but it isn't equitable either.
Kind of an important point. I don't think most people understand that or even have thought about it really, that 70% of people going into our hospitals are being subsidized, and the remaining 30% end up paying higher rates to cover the cost of that subsidy.
170 to 180%. We talk about this rising cost of healthcare, but a lot of it is just trying to keep the boat afloat. It is, yes, we have a rising cost of healthcare, but it isn't our government programs under reimbursed for the cost of care. I toured a hospital here a few weeks ago. They lose $3,000 for every birth. Every birth that comes through, and they're losing $3,000 for every baby that's born.
It makes you wonder, how can you even stay in business with that?
Well, we've got some hospitals that are not. We've got some hospitals that have closed. East of Seattle. We've got others that are verging. We've got some hospital districts that have ceased being hospital districts, have been taken over by the other entities that are in the hospital business. But we have we have for-profit, although they would call themselves nonprofit. One of the big ones lost $1 billion 2 years ago.
Wow.
It's going backwards quick.
I mean, it seems like with all these healthcare facilities closing down, people are going to be having to drive further to get care that they need, maybe urgent care, because all of the facilities are closing. We have healthcare deserts that are forming. What do you think's the solution to all of this? I mean, this is a big problem, but
Well, so we continue to hear conversations about a single payer system, socialized healthcare, and the like, but it's the socialized healthcare that is driving up health costs in Washington State, but across the nation. And I was actually listening to a podcast. It was an agricultural podcast, but they were talking, takes place in Iowa, but they were talking about the same thing. Local rural hospitals closing down, struggling, an entity that ceased to exist that the state hospital ended up merging with in order to save. This is happening in all of the states. And you're exactly right. We've got portions of this state that you have to drive 150 miles in order to get health care. And we've got sections of this state, certain counties and the like, where we're down to single insurance companies that you can insure with health care. There's a lot of misinformation, I believe, out there about healthcare and what's going on. Our northern tier hospitals in the northern part of Washington State are being overrun with Canadians who are coming south to receive care because
really?
it takes
Wait a
such
minute.
a long
So-
time for them to get health care in Canada that they're coming down into the States to receive that care.
Well, doesn't Canada have like healthcare for all, universal healthcare? Why would they be coming down here?
Because of the fact it takes so long to get an appointment.
Wow.
And so, and because honestly, they can come down here and walk in the door and get treated. And if they don't pay, it ends up on charity care.
It seems to
the
me that
hospital
would be a
Has to
a
swallow.
strong example of why we should not go in that direction, right? I mean, that
Well-
seems so clear to me.
There are other countries in the world who have gone that direction who are now going back to more of a privatized. It's the same. Anybody that has a monopoly on something, there's no pressure for them to provide a number one. So this is the
Yeah.
reason we don't have monopolies. But there is, it has been a problem in Canada, and I've got a number of friends who have come down to get joint replacement because in the United States, because under their system, it's elective surgery. So the knee or a hip, it is elective surgery, and so the doctors up there are only allowed a certain number a year. There are parts of their system been great, but you talk to a lot of Canadians. There's a large number of Canadians that now carry a supplemental insurance program in order for them to be able to receive care. And so it isn't the panacea that everybody believes it to be, because once again, somebody's got to pay the bill.
Right.
And so they're trying to limit liability.
I mean, you mentioned that there's some areas of the state where you can only get insurance via one company. And then, all of this, you're talking about monopolies. I've always thought that competition creates excellence, right? Whenever you have people competing in the marketplace, that's whenever you get better ideas, you get innovation, you get efficiencies, all of that. It seems like we're losing a lot of that in the healthcare space.
Well, we are, and we have companies that provide, for instance, kidney dialysis centers. They're largely owned by private companies. There, Oak Harbor's got one. We've got access to them, but no, they will say that they want. There's been legislation on corporate practice of medicine to keep corporations out, but I haven't seen the cost of healthcare being driven up by them. I see it by the government. Here's an interesting one. Half of the babies born in Washington State are on Medicaid. Half of the babies born in Washington State are on the Medicaid program.
Wow.
And if you under reimburse for parturition care, that means the other half of the babies are on some, I mean, they could be on, in my community, they're on TRICARE, they're on other government insurance programs. Well, they contract, and most of the time they contract for under the cost of providing that care. So the truth of the matter is that who's underpaying, driving up the costs? It's government. Again and again, like I mentioned, 70% of those walking into a hospital, and there's the laws. If somebody walks into an emergency room, by law, that hospital has to treat them. They have no choice. And then by law, they have to provide a certain amount of charity care. And by law, they can't turn over a bill to a collector. And by law, we continue to pass laws that make it more difficult all the time for these hospitals to make enough money to be sustainable.
Wow. So that's probably a reason why a lot of the hospitals are combining so that they can get that, they can still.
There are some efficiencies and synergies, but often, and we had that hospital merger bill here a few years ago, and they're all scared of the big hospitals coming in and taking over the small ones. But in one case I know of, they formed a hospital district. Within a year or so, they were not sustainable, and one of these big hospitals came in and took it over. I don't know the financials. I have a hard time seeing how they make any money at it. But had they not done that, that hospital, and it's in a small community, it would have ceased to exist had this other not come in and taken it over. I really would like, I've seen financials of hospitals. I've had them share them with me. I wish that others who make these decisions could have access to see the dollars and cents. They have to retain, you can't be completely nonprofit in respect that you can't have all your money go out for labor and your incidentals. You've got to retain some in order to be able to buy new MRI machines, which are $1 million, and new this and new that in order to maintain a level of service. Mm-hmm. So that's where the challenge is that as this equipment ages, they just don't have the money to replace it.
This is definitely a topic. I mean, healthcare, I think, is one of the most complicated policy areas in the like I work on the state budget, and that's pretty complicated, but trying to follow the money in the healthcare arena is almost impossible.
Well, so our staff for healthcare went off to another job, and I actually ended up with your staff member covering healthcare. And about 3 weeks in it, he called the former staffer and said, "I had no idea that healthcare was this complicated. I wouldn't have taken this." It is. It's extremely complicated, and and the problem is that it seems, at least my perception, is that everybody's always trying to find that demon, that villain, that's going on out there. And there are a few entities that make some money, but honestly, there's the entire healthcare industry, let's call it that, is at this point in time trying to figure out how they're going to be sustainable. My own doctor says it wasn't for his Navy retirement, he couldn't keep his clinic open. I mean, this isn't the way it's supposed to be. There has to be some money in it to keep the sustainability. And that's one of the reasons that we see these wait times for appointments at doctors and the like increasing. They're getting out of the business.
Well, I mean, let's start looking forward a little bit. You are the ranking Republican member on the Healthcare Committee in the Senate. What do you think we're going to be talking about next cycle in 2027? You have any idea of what's coming down the pipe?
Well, yeah, I do, because I just finished a Zoom meeting with our chair and staff for health and long-term care. And I've got a committee meeting actually this afternoon. Uh, Sustainability, the trying to ensure we've got a pipeline of providers coming. That, it's not just primary physicians. I mean, you go into a hospital and it's everything from nurses to physical therapists and everything else. Do we have enough people to provide the care that we need? Do we have, as I just mentioned, the profitability to be able to reinvest and see that we have that? Do we have the room? Do we have places? So I had a bill here a couple of years ago about difficult to discharge. So let's say a person shows up at the hospital and they're treated for their problem, but they've got some long-term impacts. So they've got to go to a care center. And there isn't room now for care centers. We have people who are dropping grandma off at the hospital and not showing up to take her home.
Really?
So we have had, in the one case, we had an individual in a Seattle hospital ready to discharge who was there 380 days later.
Wow.
We do not have, once again, Medicaid pays for long-term care or recovery if they have no insurance. And our reimbursement rates are so low that we just have a lot of facilities that are unwilling to take them. So what does a hospital do? They tie up a room, the cost of which is much more than a long-term care facility, but they're in that facility. We have one Seattle hospital who has actually put together a long-term care facility to move those individuals into. But most hospitals, they have people that are ready to leave, but no place for them to go.
And are these just
Especially-
people that are like elderly, or are these people
Well,
with disabilities?
it's the full
or-
gamut, but imagine a stroke victim. A stroke victim, you've gotten them back to a point in time that they could be discharged, but they can't go home. They've got to go to a care facility. There's no place for them.
Gotcha.
So the difficult to discharge patients are becoming a load for the hospital, because really and truthfully, I mean, there's some physical therapy they can provide. Otherwise, they're just taking up a bed and they've got to see to all of their needs and feed them. But they shouldn't be there. There's no place to go. So long-term care, and we've got many long-term care facilities shut down because they can't afford Medicaid rates. And I know one that has 4 or 5 empty rooms, but their financials won't allow them to have any more Medicaid. They need long-term care insurance or somebody who has an ability to pay, but they can't put any more Medicaid patients in there because it's under the cost of care. So there's that. We've got a whole raft of things that we are looking to work on, and our agenda this afternoon is full as we look. Our biggest challenge is that, as you well know, we don't have any money. So
Wow.
the state of Washington is in a position where we're going to have to concentrate on legislation that's not going to cost the state money, because we gotta make some serious cuts and not increase what we're spending out there.
Yeah, we definitely got to look at priorities. I tell you what, this is an extremely complicated area of policy, and I am so glad that you're dealing with it and I'm not. And I really appreciate you coming on the podcast and joining me today.
Yeah, thank you, Senator Gildon. As always, it's a pleasure to spend time with you.
Yeah.
A big thank you to Senator Ron Mazzal. We ask that you please subscribe to this podcast and also to our YouTube channel. The Elephant in the Dome with Senator Chris Gildon is the official podcast of the Washington State Senate Republican Caucus.